Because of time, we might just move on to the last talk. And if we have a bit of time at the end, we can have questions for both. So I'd like to introduce you to Chao-gan Yan from Tsinghua University, who will be talking about findings of brain abnormalities in depression from the DIRECT consortium.
Okay, thanks, Leonie, for the introduction. And thank you very much for organizing this event. It's my great honor to share our recent findings and data sharing. So actually, we are working on the depression imaging research consortium to how to share the data, how to use data to not just finding biomarkers, but also guiding treatment. So I have no disclosures, and I don't want to repeat because Alana has already introduced MDD as a global health crisis, but currently there is no objective biomarker yet, and people is hoping probably in the future with the neuroimaging, can we find some kind of biomarker? So Leonie and Alana has demonstrated a lot of effort on that end. And we know for one thing, probably we need big data to do that, because small data, we can have 99% accuracy, but it cannot generate to new data. So there's lots of big data, including Enigma MDD and also our DIRECT consortium. And there's the first issue is today's topic is harmonization. And myself, originally as known as a methodology and a software guy, so we do care the harmonization issue, and we have some papers talking about in fMRI how to better harmonize. Probably you have heard about combat. And we also found one called SMA, the subsampling maximum distance algorithm even performs better than combat. Combat, you always need to harmonize all the data together, but for SMA, you can identify a standard target set, and you can align every data set to that standard data set, and then you can have the harmonization. In fact, if you're interested, you can read our neuroimage paper, and we also have the software called DPABI harmonization within DPABI module. It's very easy to use. You do not need to know any programming skills to use DPABI harmonization to harmonize multi-set data. And as I was recognized as a software guy, so you can use our software like DPAS is set up more than 3,000 times, and we integrate it into DPABI. DPABI also set it more than 3,300 times. And we have lots of methodological updates like head motion, standardization, harmonization, multiple comparison correction, and you can use it all at once. So I promise you that for using DPABI, you do not need any programming skills. So it's very friendly for psychiatrists, neurologists, and for anyone to have no training on programming. And with the software development, we can combine people. So there are so many people using our software to analyze depression imaging data. So we contact them, and you do not need to share your raw data. You just use our software you already used, and you have the intermediate results of the maps. You just share the maps, and we created the Depression Imaging Research Consortium called DIRECT. And for the phase 1, we have 1,300 depressed patients and 1,100 normal controls. And our way is we do not need the sites to share their raw data. They just use our software, DPABI, at in-hospital to pre-process the data using our standards. That's the protocol. We just train the students or train the new faculties to use our software. We provide a free online course, and then they share only the final process results, and we accumulate together, and we can openly share across the world eventually. And at the phase 1, we have this kind of sample size, and we have some findings. These findings Alana also introduced. It's in PNS, is also ESI top 0.1% highly cited paper. Some findings within that is talking about default mode network. that's abnormality in depressed patients. If you want to read more, because of phase 1 data we already openly shared, you can read this into the invited review in psychoradiology, where we created this consortium and what's our future direction. And if you are interested into our phase 1 data sharing, you can access fMDog/ResMDD. It's already more than 500 groups across the world analyzing that data, and hundreds of papers produced based on this kind of data set. But this is our phase 1. For phase 2, we want to go further. When we go further, is in phase 1, we trained the psychiatrist to use DPAS. It's a volume-based analysis. But people side, if we can do surface reconstruction, do surface processing, will be even better. There are lots of ways to test that with the surface-based processing is probably 3 times better than volume-based processing. And there's lots of blocks where people are not widely using surface-based analysis. For example, there's a lack of turnkey tools, or it's a little difficult to learn. So it's a little difficult to train a psychiatrist how to install FreeSurfer, how to use the FreeSurfer commands. So at the beginning, as a software guy, we developed DPABI-Surf. This is continue the DPABI pipeline, and based on fMRI, FreeSurfer, ANS, FCell, AlphaNipalm, DCM to NIX, and GNU Parallel, and MATLAB, and Docker, and DPABI. Everything is Dockerized. And even if you have a high performance cluster, you can also utilize it. If you have 1,000 CPU cores, you can process 1,000 or even 10,000 subjects at once using the parallel computing. And with this, we trained the hospitals, the psychiatry, how to use the DPABI-Surf to do surface-based analysis. And eventually, we accumulate data for the phase 2. We have 1,600 unipolar depressed patients and 1,300 healthy controls. But if we want something sensitive, we also want something to be specific to unipolar depression. So we also accumulated bipolar disorders, 200 and 300 schizophrenia. And all of this data has been openly shared. You can visit our website, fMDog/direct phase 2 to request this data. This is a surface-based data sharing, and also we have a volume-based fMRI. So you have a Vox-wise and vertex-wise time series, all pre-processed. And this is the data for the depression data set. And as we have the surface data, we also connect with Leani and connect Paul Thompson with the Enigma MDD working group. So we combine the data together. We have 64 institutes worldwide. Previously, mostly is based on the large scale, the atlas, to see the cortical thickness or surface area. But nowadays, we can look at vertex-wise abnormality. And we saw the cortical surface. When we see the cortical thickness, they are actually reduced in depressed patients, and is a widely distributed cortical thinning. That's a very interesting issue. Probably we need to investigate further. And also we do observe some subtle cultural difference. For example, in the direct consortium, most are Chinese people, and most of the Enigma data, most of the Western people. You will see the SGACC, the cortical thinning is slightly different from each other. We are still working on this paper. But beyond seeking biomarkers of neuroimaging in depression, we are more interested in can the neuroimaging guide treatment. And recently, you may have heard lots of talks that neuroimaging guided treatment, especially TMS, basically there's 1/3 of people they will call the treatment-resistant depressed patients. There's nothing drug work for them. There's some way it's using transcranial magnetic stimulation, but how and where to put the stimulation targets, and people are all thinking about. Probably we use a 5 centimeter is a daily settings, but in the future we should use brain imaging, especially functional brain imaging, to get to select a target, because every brain has different function. But where to place a seed is the imaging community trying to figure out. And there's one way, it's using subgenuine ACC, to do a functional connectivity to find the anti-correlation at the DRPFC. So you can read the Michael Fox paper and the Robin Cash paper and others. But up to now, it's still rarely use the individualized resonance fMRI to mapping the target. There's one possible issue is SGACC is a very noisy area. So if you use a single SGACC seed to do the guiding TMS, probably you have some problems, and people are proposing some seed maps. And we are trying to this direction is because recently there's some new trials called the Stanford Neuromodulation Therapy reported very good efficacy. For example, they also use the individual as a target and with intensive accelerated trials in 5 days. And each day, 10 minutes stimulation, 15 minutes rest, 10 minutes stimulation, 15 minutes rest for 10 hours. So that have a very good efficacy. They reported a 90% response rate in treatment-resistant patients. In this way, we think in the future, probably individualized target is very good avenue to get a treatment. And we have the biggest resonance fMRI data set of the brain imaging in depression. So can we use this big data to get precise, stable, extensible data to get personalized stimulation? So we have 1,600 MDDs and 1,300 healthy controls. We can build a priori norm, and we use this kind of data set to first to look at everybody talking about SGACC, DRPFC anti-correlation to select a target. But does the SGACC, DRPFC correlation is actually abnormal in this big data set? And we confirmed that it is abnormal. We can find in the data, and we can find 2 clusters there, and we can even find the abnormal value, the t-value, is related to the clinical improvement. So probably the abnormality can have some clinical relevance to get the treatment. So we developed a pattern algorithm that we use the data, the big data proposed with Depressive. We have the SGACC functional maps. We do the harmonization, and we do group comparison. We find the group abnormality norm, and we can get individualized fMRI data using dual regression. And once we use a dual regression, we can find an individual target. And interestingly, in some previous data, they have correct neuroimaging data, they have TMS treatment and the location and the efficacy. And we found if the stimulated site is closer to our individualized target, the treatment efficacy is better. And in 2 different data sets. And if you use other group target, you will not find that good efficacy. So we think in this retrospective data set, we seem to have this kind of good effect. You can read our paper at Science Bulletin this year. And we're trying to prove that we need to start some clinical trial. So we're trying to, in the direct consortium, we have multi-site, and we have different targeting algorithms. We're using the robots to place the coil and precisely stimulate the target. And this is our regular setting. We have a psychotherapy counseling room. We have a team psychotherapist, and we have the TMS robotic arm. Those are cameras to know where the robotic arm is and where the head is. And we calculate the target through the big data, and we input to the robot. And this is our regular settings. I talk to every treatment-resistant depressed patients. They are quite suffering. But luckily, through our big data gathered individual TMS target process intervention for depression, our first stage, we have treated 30 treatment-resistant depressed patients. Some of them respond well, and some are not that well in 5 days. And we can see the Hamilton depression, and anxiety and MADRS all have the response in this kind of patients. And as you know, they are treatment-resistant patients, very difficult to treat. And after 1 week, still the treatment effects can maintain, and they can maintain for months and even for half a year, and some of them are even maintained for years. So seems we can pretty good for treating the treatment-resistant depressed patients. But in the future, we do hope using brain imaging, we can know if a person has some kind of depressed, but what kind of treatment is best working for you, because we have psychotherapy, we have TMS, we have medication, and utmost is we can create a social network. It's not just we scientists or psychologists. We have psychotherapists, we have social workers, or we have educators, or we have governments to all support the depressed patients. And for anybody who are interested in using DTI data, I just advertise a new software pipeline called Depressive Fiber. Once again, you do not need to know any programming details. You just click the buttons and it can do the whole brain fiber tracking. And this slide, I hope you can take a photo, because there's a very important URL here, alphamdog/direct phase 2. You can get access to direct phase 2 data. We have 1,600 depressed patients, healthy controls, we have bipolar, we have schizophrenia. You can play the data. So all the open source data. And this is some documentary, and I would like to thank my students, collaborators, and thank you very much for your attention.
Thank you so much, Chao-gan. Fantastic work. We're at time. Just very quick question. There was one question about the TMS results from 2 people online. Did you use a placebo or sham TMS arm?
Not yet. So the first 30 patients is open label, because we want every people come to us, because we are not a hospital, we are a research team. We deliver them what we believe is the best. And later we will do under control, but it's not a sham control. We will use some traditional F3 beam as a control. So because they are treatment-resistant depressed patients, we really don't want to just give a placebo, but we can give some conventional F3 beam to them. And our philosophy is, if we acquire data, probably thousands of patients using precise TMS target. Probably our algorithm is not the best, but if we have thousands of people, we can optimize the algorithm based on thousands of coordinates, treatment efficacy, and brain imaging. And that would be a better algorithm, I think.
Thank you. And there were a few other technical questions, I think, around whether these methods like half-pipe and other ones can be used within a cluster where you only have command line. Yes, that can all be done. Please feel free to talk to Elena about how that's done. Whether half-pipe can be incorporated in NIPOPI, I think there's plans for it.
Yeah, there's a plan for that. Yeah, I think, again, NIPOPI is more like a general framework. Half-pipe is a series of specific tools. So I think in terms of engineering, it's probably a better way to actually split the different things in different separate components. I mean, that would be my engineering kind of hat on for half-pipe. I think it's so maybe what we'll do is cut the different pieces that are and then integrate that in the NIPOPI framework. I think that's probably the best way to move forward. And that would make that also more flexible in terms of updating things and
So we're at time, but do feel free to just come up to the presenters to ask questions about the data sets and the pipelines. I'm sure they're very willing to answer it. So just please join me again in thanking all the speakers for these wonderful presentations. And thank you all for coming.